one of the things too within the PHQ-9, there's several items on there that if you might equate just being there simply because they have chronic pain, like you're not sleeping very well, your appetite's crummy, you're not interested in doing anything. And you might be tempted to say, well, just because they have chronic pain, then they don't really have depression because these scores are just because they have pain. But this instrument's been validated across all kinds of disease conditions, and other types of things too can give you problems with eating or sleeping. It doesn't mean they don't have depression. Just because, in other words, you can't write it off as, oh, that's just chronic pain symptoms. If they're scoring high on this, it's been validated, they have depression.
But doctor, of course I'm depressed, I've got pain.
Well, one thing to remember too with PHQ-9s, and David's alluded to it, and MOAs to be thinking about this, and PSP people that are working with offices, it's amazing how many offices have patients coming in where the doctor has no pre-knowledge and the staff have no pre-knowledge of what it is the patient is coming in for. And that critical piece of information, I'm coming in to either renew my pain medications or because I've had this sore back that I'm coming back to check on, recorded so that the staff and the doctor know, is going to be the key here to that workflow of, okay, somebody's coming in with chronic pain, somebody's coming in that's depressed, I need to hand out this, and I'm thinking as an MOA, I need to hand out this information before the doctor sees the patient. So that it gets done.
The appointment as well.
Yeah. Or get the patient to come in 5 minutes early because we have a little form we want you to fill out.
Try 15,
yep.
20. I was teasing Michael there about the depression and pain. Of course I'm depressed, I'm in pain. It gives you a good segue into the fact that, of course your depression might have been caused by the pain, but if you treat the depression, the pain is going to get better. It's a two-way street.
The GAD-7, the General Anxiety Questionnaire, is also in the mental health module, right? Yes. Yeah. And I use this one as well, just to get an idea of how much anxiety the patient is experiencing. And then if I see certain things on there, I'll ask them, well, what is it exactly you're worrying about? What are you afraid of? And just try to get into the cognitions a little bit about what's driving some of the anxiety if I can. Wes is our psychologist on the content group, so.
Thanks. Well, one of the things you can do that's really helpful with your patients to join with them and really give them a sense that you're tracking them well and understanding what they're saying is just take a look at extreme scores. Make sure you mention them. Well, I see you got a 4 out of that. Like, that's a lot, right? And then take a look at the ones that are not extreme, that are very low. Say, you seem to be doing well in that. You can actually use that little technique right there. Even if you just said it, the person feels understood. And it also helps them to know that it was worthwhile for them to fill out the damn form.
Yes, that's always helpful.
David Hunt has got something to say here.
I just wanted to reinforce the fact that yes, there's 3 things we need to be concerned about: the pain, mood, and sleep. And they're all interconnected, and if we don't address those all 3 together, we won't be successful in managing mood or pain.